I was telling somebody earlier that the last time I spoke to a crowd this large, I was in Beijing, and the entire audience was the Red Army, and I don't think they were there of their own choice. So today, we're going to talk about something that I think everybody is aware of and has experienced it by themselves or with a close friend, and that's back pain. And the purpose of today's talk is to educate you as to why do you hurt? What is the scope of the problem? Who is at risk? And then what can be done about it? I think the first thing that's critical to remember is to the old adage of listening to the patient. Back pain is not simply back pain, and there are reasons that you hurt. You have to be looking for infections. You have to be looking for potentially cancer. There's many other things, kidney stones, etc. So it's important to listen to the patient as you try and formulate the approach to develop a strategic plan to help the patient out. So first, I'd like to spend a few minutes going over the anatomy, so now you'll know more than most of your friends who did not show up. But this is the spine here on the right. That is the foundation of your body. These are the backbones here. You can see clearly here, that's the vertebral body, they call it, right here. You have the disc in between. Behind the disc, you have these joints called facet joints, and they're the load-bearing small joints behind the disc and the spinal canal. So it's kind of like, I tell patients, it's like a three-legged chair. So at each one of these segments, here, 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 and here, you have a three-legged chair with the front leg being the disc and the back two legs being the joints. So this is a cross-section of what we just looked at. You can see the disc right here. That's the shock absorber. That's the spinal canal. Those are the nerves that exit. And these are the joints which are behind that, called, again, the facet joints. And I think it's important to have a good understanding of the anatomy, particularly as physicians, as we're trying to sort out what is causing your pain. So, interesting just looking at the overview of the statistics regarding back pain. It is a leading cause of work productivity in the United States. It's a leading cause of disability. 80 to 90% of the U.S. population will experience severe back pain at least once in their life. About 10% of those will evolve to a chronic pain which is unrelenting and lasts for more than a year. And about 15%, amazingly enough, will not have any specific diagnosis whatsoever. And so we're here to change all that. So who is at risk? Interestingly, genetics plays a big role. So oftentimes I'll ask my patients, tell me about your family. Did your parents have back problems? Because there is a significant genetic component and it does affect the disc. This was a recent study that was done in, or published in the Journal of Spine in 2008, which looked at approximately 300 sets of twins in Finland, looking at MRI scans and hospitalizations and their disability, and found a significant genetic component linking them. The other risk is weight. There was a recent study published in January which looked at people that had undergone bariatric surgery, and that's that weight reduction surgery. And after having lost about 60 to 80 pounds, they actually saw an increase in their disc size. So weight is a significant contributor. And this was, not only did they see an improvement in their disc or shock absorber, they saw an improvement in their pain, they saw an ability to do certain tasks. So weight is a big issue. Smoking. Smoking is a disc killer. The disc, you would not know this, but the discs do not have a good blood supply to begin with. And so when they have to compete with a cigarette smoke and the carbon monoxide then they essentially get suffocated. So one study looking at 5,333 patients, the people that were smokers had more pain. The people that were able to quit smoking had an improvement over time in their back pain and their functional status. Posture is important, and of course, mechanical forces. Kind of goes without saying. I think that little girl will be hurting later the next morning. So let's talk about the different components of back pain and kind of break it down and see what can be done. Muscular is the most common. That's the kind that typically resolves after a couple days. Typically treated with ice, stretching, NSAIDs, which are like Advil, those kinds of medicines. Chiropractic is good for that. Physical therapy is good with that. And injection-based therapy, which is our particular specialty. And before I go any further, I have to say one thing. There's some people in this room that advocate the use of turpentine for this kind of thing. And Mom, let me just tell you, that's bad for my business. So quit spreading that rumor, okay? So going back to the joints, we'll start with that, looking at the muscles and then the joints. These are the joints right here, again behind the spinal canal, oriented longitudinally there. It's interesting, in younger people in particular, I've seen it in wrestlers, cheerleaders, gymnasts, tennis players, golfers. Anybody that has a rotation of their spine can tear those joints, and it can be a severe, unrelenting pain. It will also just increase spontaneously as we get older because you'll develop arthritis in these joints. It's usually not in the middle. It can radiate down below the knee, typically kind of the buttock and the knee. And it's a high incidence as we age and get over 65. Very common, in fact. So what can we do? Well, we have the ability to do a very precise injection, which is very safe. And we take a needle and just place it right on the nerve that supplies that joint. So we have the ability under X-ray guidance to place a needle right into that joint and inject the very powerful healing medicine, which is typically a steroid and a little bit of numbing medicine. The beauty of that is, we were talking earlier about why do 15% of people not have a clear diagnosis? The challenge is you can look at the MRI scan, and as we age, you'll see abnormalities on almost everybody, but you don't know which particular abnormality is responsible for their pain. So this way, you can anesthetize what you think is the particular culprit and then re-examine people upon completion of procedure, and if their pain is gone, then you make the conclusion that that is the source of the pain, and then you can make a very strategic, focused plan of attack, whether it be physical therapy-based or medication-based or injection-based. This is just another example, again, of the needle going in and putting medicine under that nerve that supplies the joint. Now, in addition, the beauty of that is sometimes that will give you short-term relief. But if you establish the diagnosis and we feel good that that's where the pain is coming from, the next step is to use what we call the radiofrequency needle, or laser needle for short. You place it right under this nerve right here, and you can burn that little nerve. Now that nerve is about the size of a hair, and it lends itself very well to burning it, as opposed to cutting it out and cutting all that bone out with major surgery. It's a very elegant procedure. It takes about 60 seconds to 180 seconds per level just to burn that nerve. Then typically you get about 9 months of relief. I've seen it last for a couple years, sometimes shorter, but average is about 9 months. And very safe and very elegant. So, what's the next component? The disc, the shock absorber. I see it more and more in younger people. I've seen it in people as young as 14, 13 years old. We used to think that didn't happen, but with the advent of MRI scanning you can now image these younger people, and it's pretty amazing to see a 14-year-old with a big herniated disc, but I have seen it. The other interesting phenomena is, historically, if you look at the sort of orthopedic school of thought, it was as we age, the disc will, quote, burn out and not hurt. Well, we have the means to actually study these discs and determine whether or not those discs are painful. And I can tell you for a fact that those discs can be a source of significant pain as we age, and they don't, quote, necessarily burn out. Typically, that pain will increase with sitting. You may or may not have sciatica. It's not a true statement to say, well, it must not be a herniated disc because I don't have leg pain. Whether or not you have leg pain really is a moot point. You can still have a herniated disc or disc degeneration or a painful disc and not have any leg pain. Most commonly, you would think it was lifting something heavier or, lifting a car or something crazy. Typically, as I was brushing my teeth and felt something pop, or I was shaving, and that's typically the story I get. But again, remember, this is nature's shock absorber, and it is related to an injury or a degeneration. Now, the next slide is a little bit graphic, so I'm warning, if you've got a weak stomach, you may not want to look at this. So that guy's going to have a little disc pain. Things did not go well for him. So it can be an injury that starts the process, certainly. No, it did not. But interestingly, we see a lot of athletes, again, a lot of people that are not athletes. For a time, interestingly enough, I was seeing a lot of gymnasts. And for those of you that aren't exposed to that, the female gymnasts sustain a lot of injuries. And therefore, that cheerleading that they do, which is kind of like a hybrid of gymnasts and cheerleading, they sustain a lot of injuries and a lot of back injuries. And so they have all kinds of rotating, twisting, spine loading injuries as they do their events. I've actually seen more cheerleaders than football players with bad disc. It's kind of amazing. So here's another picture of the disc just in a cross section. And here's the disc. You can see the little bulge where the arrow is. Sometimes it will put pressure on that nerve and cause inflamed pain going down the leg. Sometimes it doesn't have to be right. Sometimes it can be right in the middle. But that's, again, a cross section just of the disc right there. Here's a side view of what the disc looks like. You can see a normal disc up here. See, this is starting to degenerate. Remember, these are the shock absorbers. Bulging disc right here. A herniated disc. That one's losing its cushioning ability. And these show more of the chronic changes over time. You see the sort of rattiness along the bone there. So again, imagine, it makes sense when you talk to people and they say, I've got no cushion left in my knees. So what happens when you stand up? It hurts. That makes perfect sense, doesn't it? Well, does it not make perfect sense that if you got no cushion left in your disc, that it's going to hurt? So that's another common source. The other interesting thing, going back to what we were talking about earlier, is in the body's attempt to compensate, what happens is they will shift the energy back toward those joints which are behind the disc. And so then we can target that and treat the pain by blocking those joints, the nerves, those joints we were talking about earlier. This is an MRI scan image of the disc, and you can see here these discs are very dark, and that's the beginning of the degenerative process. So in MRI scan terminology, that disc has a normal signal. This white has got a good fluid-filled capacity, normal liquid content, and as it gets brittle and more degenerated, that's what you see. So one option, non-surgically, is to go in there with a small needle and place it behind the disc and put the medicine in right there. That's commonly referred to as an epidural. Now just let me say right here that, of course, there was some, rightfully so, some concern and alarm about those deaths that occurred earlier in the year from the contaminated solutions that were made from a compounded pharmacy. We don't use a compounded pharmacy. And that's basically when you're taking chemicals and you're mixing them together, they're not pure, and you're trying to create something else. Well, here, we use all pure medications with no compounding. This is an example of putting the needle onto the nerve where it's been pinched, as you remember the slide a few slides ago. And that's how we can very elegantly and precisely do that and steer the medicine right on the root of the problem. I mean, imagine when you take an Advil or a Aleve, what percent of that medicine do you think reaches the problem? I mean, it's 0.001% or something like that. This is 100% of the medicine where the problem is. So the success rate is pretty high. I would say it's close to 60, 70%. You know, of course it changes as we get older and you got multiple levels involved, but in a single level disc, you have a pretty high success rate, and I think this is a nice way to deliver the medicine directly on the root of the problem. In addition, the beauty of this is, from a diagnostic standpoint, we can, after our examination, after a careful review of the MRI scan, you take and you pick the nerve that you think is the most in question, or two, and you can isolate them like isolating an electric circuit, and you just simply anesthetize that nerve. Then you reevaluate the patient, and then you have an instantaneous, real-time evaluation of whether or not that disc is causing their pain or not, or that nerve is causing their pain. So it's a very minimally invasive, precise way of isolating where the pain is coming from. So what do you do when it's just so bad you don't have many options? There, of course, is medications. We live in a medication society. And I think we have to remember that all medicines are not benign without side effects. Roughly 600 people died last year in the state of Georgia from narcotics overdoses. 720 the year before. As you know, Florida's been dealing with that. Now all that problem has just shifted up here to Georgia, and we're working very diligently to clean that mess up. But there are physicians out there that are not approaching this very ethically, in my opinion, and they're just handing them out like candy without looking at the side effects. So I think it's not that pills are bad in and of themselves, but I think they have to be thoughtfully given, after a thorough exam and a plan that has your safety in mind. The other thing is physical therapy. I think physical therapy plays a key role in your long-term outcome. I think not only for pain relief, but as well balance and stability. The risk of falls goes up as we get older, and particularly if you're taking a bunch of medicine. I liken it to, you get up in the middle of the night, you wear glasses, you've taken a couple pain meds, your foot gets caught in the sheets. What do you think your odds of a hip fracture are? And then the mortality goes up. So you have to take all these things, and if you're dealing already with pinched nerves from here down, the things that we take for granted, I know where the floor is. I don't have to look down and know where the floor is. I know. But if you got diabetes, you may not know where the floor is. You may not be able to feel it. If you got a pinched nerve on top of that, I may have no idea. I may think the floor is not there yet. So it's night, 3 in the morning, I've taken 3 Lortab, muscle relaxant, I've taken some other medicine, so I'm a little bit wobbly, don't have my glasses on, it's dark. I'm just at a high risk of falling down and hurting myself. They've done some interesting work in terms of physical therapy, which actually look at your recovery from conditions like spinal stenosis, which is the pinching of the nerves up and down the spine. And they've actually found that people get better in their functional status by working on their core muscles and their balance, just from that alone. So I'm a big believer, and for the reasons that I just mentioned, in terms of trying to improve your balance and stability, in addition to us working on the pain. What's another big factor that's very prevalent in our society? Osteoporosis. There's more than 700,000 fractures a year. As you know, it increases with age. Women are at greater risk, and if you're over 80, 60% of you will have fractures. These are not benign, insignificant occurrences. It affects your lung capacity to expand. It affects the mechanism of your intestines to work. The rate of mortality goes up significantly with compression fractures. So here's a compression fracture on the MRI scanning. See, it looks like here's a nice looking vertebral body, and there it's crushed. And these things are very painful. It's interesting because, again, 15 years ago, people say, take some Advil, lay down, you'll be better. I mean, of course, when I was younger, I might have believed that. But the older I get and the more I heard, I realized that things don't always get better on their own. And in fact, we developed some procedures starting in about 1997 where we can take big, what they call trocars, but it's a needle that's placed into the backbone. We blow up a balloon, we re-expand that bone, and then we fill it with cement. And that's about 95% effective in taking away the pain associated with that fracture. Highly successful, in my experience, highly safe. And instead of having to wait 6 weeks, 8 weeks, we can do this procedure in 20 minutes. And it is 95% effective for that particular fracture. So that is something that is one of the more effective tools that we have in our arsenal against these severe compression fractures. So what's the other big component? This is the person who's had major surgery. You know, surgery most of the time works very well. Sometimes it doesn't. And so then what do? Well, and most of the time it's not just I've got leg pain, I've got back pain too. And it's complicated. You've got a lot of things going on. So part of our job is to evaluate you thoroughly, do the conservative things first, but if the conservative things fail, then we have this really amazing technology where we can do an implant of like a wire, and it's like a pacemaker. And you can see right here, it just goes right behind the spinal canal. And amazingly, we can control that electric signal to deliver a very soothing pain relief right down your back and leg. And so that's been a breakthrough, which has really been present for about 35 years. I mean, it's not exactly a breakthrough, but we've gotten more and more refined in our ability to use it and therefore pick our patients wisely and get the best outcome we can. And so this is the little battery pack that is utilized to control it, that you control, and you can control the signal. So it's under your control, which is one of the beauties. So instead of having to take in a bunch of medicine, you can hit the pacemaker, for lack of a better word, control the signal, and get a soothing feeling radiating down your back and leg. So who is a candidate for that? Basically a non-surgical person. They've got back and leg pain, nerve damage, previous surgery, they failed conservative care, and there's no reasons medically not to do it. In fact, we looked at a group of people and published on this a couple of years ago on people with spinal stenosis. People that are historically destined for big major surgery. Well, where I came from, I worked with the neurosurgeons and spine surgeons. And they would say, we don't want to operate on this patient. Well, that's a big, huge surgery. And he said, why don't we do the spinal cord stimulation? So we would do the spinal cord stimulator, and the beauty of it is you can do a test period or a test drive, I call it. So we slip it in, you wear it for 4 days, and you see how you like it. And what we started doing was we started getting exercise treadmills before we put it in, and then while it was in during the test period to see how your walking capacity improved. And lo and behold, what we found out was that your people's walking capacity would improve from, say, 2 minutes to 8 minutes. 3 minutes to 12 minutes. And if you're housebound, if you can only walk from one end of the house to the other, now all of a sudden you can walk out to your mailbox and back. That's pretty significant. So this was a nice non-surgical way to give people relief And then you could always do surgery down the road. But if this gave you relief, it spared you a big major surgery. And this is just some examples of what it looks like in your body. So, to summarize, you may find yourself in a position where you need some help. You may do something stupid. So we are here to help you at the Thomasville Pain Center. I'd like to introduce my partner now, Dr. Ward, if you'll stand. We're going to have a new location over in Gordon Avenue, and we'll be moving there hopefully in May. And you know how that goes. But I'll be happy to take any questions that you may have now.
I'm a scoliosis patient, and I have an S curve, so I don't, as the doctor said, don't look like I'm needing a V8 all day. No. My second curve down is now almost at a 90-degree angle. And I've got spinal stenosis and arthritis and every little thing all the way down. Would any of that, by that implant, would I be a candidate for that, or would that be just too much for the scoliosis?
The question is, if you have scoliosis and it's severe, would you be a candidate for any of these implantable therapies? I think it goes back to, you know, that decision cannot be made without a thorough examination. I think looking at the conservative therapy first, and you may or may not be. I have done it on scoliosis, and then there's other implantable therapies too, depending upon the situation. But so it's a little too early to tell just based upon that. The goal is always simpler is better. And if we can make you better with the simple stuff, that's better. That's my non-answer.
The other thing you realize too is that there's some arthritic changes because in your spine curve, each one of those facet joints are lining up inappropriately and different. So sometimes we can identify, you know, which ones are the major contributors, not that there won't be more of them, but control a large portion or a big portion of the pain. And you know, Bert was well taken about sometimes you don't have to get complete pain relief. In fact, most of the time, one of the things I always tell patients when they come for the first visit is, you know, complete pain relief is probably unrealistic. But if we can get you more functional and, you know, get you in the 50 to 70% category, you're going to appreciate it.
I agree with that.
Mine's two-part. First is, what do you think about regular monthly chiropractor adjustments, the wear and tear concern, and then what do you think about conversion tables?
Is that a two-part question or a three-part question? You're checking my math skills, aren't you?
Well, the wear and tear damage from regular monthly chiropractor.
I think, you're asking, we approve of the use of chiropractor as far as the...
For any concerns getting regular monthly adjustments for your, you know? We have patients that see chiropractors when they come to us, and I refer patients to chiropractors. It depends on the stage of the disease process. It also depends on the anatomical structures in the spine. And if you have a herniated disc that has the spinal cord entrapped, that's not a manipulative type situation, obviously, but you have to know that before you do that. But yeah, it can be an important part of the overall care. Your thoughts on that?
I agree with Dr. Ward. Again, I think it goes back to, are you getting better? You know, and I think if you reach the point where you're not getting better, then I think you need to look at other modalities of treatment. I think the other issue that is raised is, you know, at what stage in the disease process are you? And then the final thing is, you know, not all chiropractors, just like physicians, they have different ways of doing things as well. So it's kind of hard to generally answer that. Some use the activation, some do use the spinal manipulations. They all do things a little bit differently.
If you get them over and over, is there any concerns for wear and tear on anything? I mean,
just,
As far as the manipulations themselves,
I don't know the answer to that.
what about inversion tables, y'all?
Oh, yeah, inversion. You know, that's like an inexpensive traction device. I think that's fine.
just make sure you have high quality food.
Yeah.
The guy that invented the teeter totter, I think, slipped out of his seat and broke something.
Yeah.
Chandler, for those of us golfers who have rotational pain, is there a downside to injection therapy for further injury, risk?
No, it doesn't anesthetize you permanently. You still feel things, okay? So I don't see a downside to that.
I would agree.
Degenerative bone disease.
Degenerative bone disease.
Well, that, are you referring to degenerative disc disease or just arthritis?
Disc disease.
Okay. Degenerative disc disease, it depends how many levels are involved. It depends how extensive it is. You may remember, if I can just do this real quick. Yep. So here, you have the disc that is beginning to degenerate up here. Here it's gone through that process, it's really degenerated. Here it's even more degenerated. Again, you have to evaluate the patient, which is part of the experience, because if you have, over time, your body will try to compensate and it will shift all the energy back into the joints. And you can treat that by targeting the joints. Now, interestingly, depending upon the stage, this is one of the more interesting things to me. You know, they're looking at some novel therapies. They're looking at the stem cell injections and various other injections that you hear about, but we're just not quite there in the U.S. I keep thinking they're doing some really kind of novel stuff. Now, this is kind of interesting. I mean, how would you not love this? They do liposuction. They take that fat, they spin it down, and they inject it into your disc. That's a win-win combination, right?
It's kind of like arthritis when you got bones rubbing against one another.
That's what I was saying earlier. It's like your knee. You got no cartilage. But they're doing some stem cells, but you'd be too far gone at that point. You want to try and catch that at that point, and that's still in the experimental phase.
All right. Is it possible to fuse those joints together to keep that rubbing from minimum?
The only way that occurs is with a major surgery and a big construct put in there to jack it up. Yes, that's possible.
All right. So
Yeah.
this problem's not going to get better. It's going to get worse over time.
That's the natural history of arthritis is a slow progression.
So if it's happening in 2 or 3 discs, is it going to go up the back? Is
Well,
it going to continue the rest of them?
Again, typically, you know, the discs that are affected the most are the bottom disc. And it sort of depends on what your occupation is too and what the forces, like you were talking earlier about the scoliosis. It kind of depends where the mechanical forces are on the spine. So some people have it, interesting enough, more higher depending upon their occupation. But the majority of Americans is going to be right down in here.
All right, the injections that you put in there to alleviate the pain, you say they'll last anywhere from 9 months to 2 years.
For that particular procedure, where you burn that nerve, that was more for the joint pain, not the disc pain.
Will that work with this?
It can, and again, it's hard to say that without an examination and determine whether or not the person is appropriate for that.
Are you able to do that in your office?
Oh yeah. That's what we do. Yeah. Yes.
How do you correct an aching sciatica nerve? If it's pinched, what do you do?
Well, again, So how can you correct an aching sciatic nerve? If it is pinched, what do you do? Well, the things that we do, you can see the disc herniation here, the disc bulging out. Those are pinching nerves that are coming out right there. Go back to you. Oh, yeah. So here you have a disc pinching on that nerve. Okay? So we have the ability to take a little tiny needle and slide it right there. And it's like spraying WD-40 on the inside. And it lubricates that. And in fact, it reduces the pain. And the reason it does that, because one of the reasons that that hurts, that's like an intense chemical reaction, like pouring bleach on your skin. And it's doing that to the nerve right there. So we put the fire out by putting the healing medicine right there. And that cools it down.
The other thing to realize too about sciatic pain, the sciatic nerve is a combination of multiple lower back nerves. So when you say sciatic, to you guys, you're thinking it's one nerve. To us, it's 3 or 4. And so the first thing we try to do is figure out, can we isolate it and get it selected down to something more specific before we start treating.
Okay, if you have, your back's not hurting, but your legs do, and they say it's from the sciatic nerve. And there's more than one nerve going down your legs, so all of them hurt, so how can you?
Well, that's why you come see us. We'll help you figure it out.
I have a question over here. Okay, for as, I guess I'm getting a little different, for your bed, like mattresses and all that kind of stuff, what's the impact of that on your back and your muscles? Soft bed, and sometimes, you know, you swamp down and your back and stuff, early you get up and it's better. But your bed is a lot in
I will let you know.
There you go.
That's a firm bed.
You know, people ask me that, and I don't think there's any literature that says one bed is favored over the other one. I just tell people, get what feels good to you. I mean, whatever you feel good at in the morning, that's the bed you get. I've had people that come in and go, doctor, I want you to write me a prescription for this, you know, $10,000 bed. Well, you know, or they come in and they go, I spent all this money on that number, what's that number bed?
Select number bed.
Yeah.
It doesn't work.
There you go. Thank you, ma'am.
No matter what number I put it on.
Yes.
What is the new technology for disc replacement surgery? Is that different than obviously injecting it with the cement?
Well, the cement is not for the disc. That's for a compression fracture of the bone. Okay, the disc replacement, you know, interesting, the Charite disc was on the first artificial disc, and the theory was that that would be better because it would more closely replicate what your body does, and that was a big advantage. Okay, when you go in there and, let me see if I can get to the that slide. One of the big worries, and I'm kind of getting a little bit out of my area of expertise right here. Look, let me back up. This was the older way of doing the fusion, and you have these rods and screws in here. Now they approach it differently, and they'll approach it from the front in many cases, and they'll put the wedge right in here, or the artificial disc down in here. And it's felt to have some advantages, and really a surgeon could better address that. That is a newer way, and it does have some advantages as opposed to going in through the spine. But it's just a different, more invasive way of treating the disc problem rather than injecting. And so, again, the thought would be, if we can get you better with an injection, that's a lot better than that.
How many
times when you have those injections? I'm sorry, I'm working on it. I'm having epidural next
That's
week.
okay, we'll give you another. Like most medicines, we base it on body weight and milligrams per kg, distributed over time. Of course, you know, like everybody is different about most medicines. You can be about steroids as well. So Dr. Chandler and I are always watching for side effects and things. But in general, it works out to 3-4 months minimal in between. We'd like it to be once you've had the injections, so, you know, 3 per year. The other thing is, there's not a standard set dose of the medication, and one of the things that Bert and I both do, even though we're new partners together, I noticed right off that in the old days, when I was back in the OR doing anesthesia, and we do epidural, we were using 80 or 120 milligrams of epinephrine. You just don't need that much epinephrine. So we use smaller doses now, so the frequency can be closed a little bit. One of the most frustrating things I hear from patients, you know, in pain management, is not cure, unfortunately, is, you know, the repetition that's involved in it. So it's really frustrating for you. And I try to deal with that initially on the first visit when it's just, you know, where we are right now, and we just have to accept that. So by managing your doses, if, you know, you need injections a little more frequently, then we just make sure you don't get more steroids.
I would just add that I think it depends upon the situation. You know, you've got to look at what your alternatives are. You know, and so I've had plenty of people that the surgeon sends and he goes, I cannot operate on this person. It doesn't matter what. They had a major heart attack 2 months ago. They'll die on the operating room table. And so then you have no choice. And I've had plenty of people that I do every 3 months. I mean, it's like clockwork. And that sustains them and allows them to get by with what they do. And I feel pretty good about it. You know, obviously, if I got a person that we do several injections and there's no reason not to have surgery, then I'm going to send them to the surgeon. The goal is not to waste time. The goal is the best patient outcome that we can possibly get, whether that be with physical therapy, chiropractic, medication, doing the things that we do, or sending to the surgeon for what they do. The goal is the end point is your improvement, period.
One more follow-up on that. The other thing too is remember that not everything we do is steroid based. We have the radio frequency therapy, the stem therapy. Those are non-steroid based. So not everything we do is steroid based.
Yes, I have degenerative disc disease in my back and in my neck, and my neck is worse. So would those treatments help your cervical also?
The short answer is yes. The obvious part of that is, you know, the evaluation is emphasized so much, and doing that appropriately, both physical exams and diagnostic studies. And then once we know the stage you're at, then you know we can better.
Well, right now I have a pinched nerve and it's killing me.
Okay, come on down.
But I think you make a very good point, and that point is that it's not uncommon. You know, we age at the same rate. People are sometimes so surprised. I've got neck and I got back pain. Well, you know, your spine's aging at the same rate. It doesn't selectively not age. So what's happening down low is typically happening up here.
Back in high school, I hurt my back playing football, and I eventually had it x-rayed, and the piece of the vertebra was broken off, and eventually, from time to time, it works its way, it pinches up against the nerve. It's not at the time comes at 7 one day, it's going to catch, it just hurt like heck. We'll take it out then. Is there anything now, that was 40 years ago, is there anything now that we can stay away from surgery? That's
Don't play football.
just referee.
I think you're rolling. You look pretty good. I'm not aware of anything for that sort of
No cigarettes, keep the weight down.
Yeah,
Those are the best things you
weight
can,
did help.
those the best things you can do.
Yeah, man, like a cop up.
You know, as long as you can enjoy it, you know, I tell people, do what you like to do. That's what gives you satisfaction in life. We'll try and help you do that.
Absolutely. One other thing I wanted to reemphasize that Dr. Chandler talked about here in the talk, and nobody's asked a question about. We did talk some about chiropractic manipulations, but physical therapy is not physical therapy, is not physical therapy. There's rehab physical therapy, and there are about 5 major disciplines of physical therapy. And the discipline that we need in chronic pain is specialized. So when we're talking about physical therapy and strengthening core muscles and that sort of thing, we're not talking about sending you somewhere where it's just on a bicycle or a rowing machine or that kind of thing. That's not the discipline. So just so you understand, like most things, there are different disciplines in it, and getting the correct one is a very important point.
Did you do all those procedures in your office?
Right now, we do it here, and we'll be doing it in our office. Yes, sir.
The overnight stay?
No, it's go home.
Pretty large.
Well, some of those procedures, like where you put the cement in, you might stay overnight. But the other needles, you go right home.
We use sedation, sometimes IV, sometimes intramuscular, depends on the procedure and the patient. We talk about that with you when we're setting up the procedure. We try to get a feel for who you are as a person and deal with you individually.
I have a pinched nerve in my neck that causes, there's some numbness all the time, but certain ways I move, it's more numbness. Can that be alleviated?
I would say you need an evaluation. You need to have an MRI scan if you not have one. And you need to let us take a look at you, because it might very well be, but we need to look at that and see. Sometimes you need to understand that sometimes, you know, that may not be just a pinched nerve here, because you can pinch anywhere along the telephone cable. So we need to, that's why we need to do the examination and look at you. But you're absolutely right. When you turn certain ways, if the nerve is pinched up here and you crank that way, it's going to compress that nerve just a little bit more and aggravate it.